Hello, welcome to the Geri Academy podcast with your host, geriatrician Dr. Golnur Sharafsaleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media. Hello, and welcome to the Geri Academy podcast with your host, Dr. G. Today, I have a very special guest, Dr. Rahul Sampath. He is an infectious disease physician, and he is the program director of the internal medicine residency at UNC Blue Ridge in Morganton, North Carolina. He happens to be my very good friend and colleague, and I follow all of his infectious disease advice related to COVID, and that's what I wanted to talk about today. Hello, Dr. Sampath.
Hi, Dr. G. It's a pleasure to be on your show. I'm very excited with the conversation topics that you have chosen for today.
Thank you so much. So basically, I wanted to start out by asking you if you could give us a brief update on COVID, where we started, where we are. And I wanted to tell you, I remember, was it December of 2019? And you and I were in the physician lounge watching something, like it was a news station, and you were like, it's coming, even though everyone else was saying it wasn't. And it was like, oh my gosh, we have to prepare. It's coming. And I think with your leadership, our hospital was so well equipped. So thank you for that. But give us an update.
Thank you, Dr. G. And, I have to say that infectious diseases, being an ID doc, I'm a little biased and paranoid about any virus I see on the news. So I may have had a little bit of a polarized opinion. I did think back in 2012, MERS was also going to eat us alive. And I did think back in 2003, SARS was going to be the pandemic that defines us as a generation. I was wrong on both those occasions, but 1 out of 3 is not a bad score, I guess.
Okay.
And thank you about your kind remarks. I obviously had a lot of help with all the decisions that we made along the months that followed COVID-19 back in early 2020, when we started making policy changes and stuff. But it's been a long journey, and that's just what coronavirus is. It's a class of fairly common GI viruses that we've dealt with, as human beings for many centuries as we evolved with them, and we did deal with 2 others that were relatively significant because of their high mortality and ability to spread. In 2003, we had SARS, and we had 2012 MERS. And now in December 2019, we had an outbreak of SARS-CoV-2, or COVID-19, as the clinical syndrome is labeled. And I don't know that I don't know anybody that anybody could have called how it would just explode into this international disaster of epic proportions. I think there was a recent analysis that looked at the mortality that COVID-19 has caused thus far, and it eclipses the mortality that was seen in both the World War I and II put together, as far as troops dying, and that was just shocking. So, and it's anticipated to take more lives all the way into 2022. But I think right now, compared to where we were a year ago, we have a few things that are definitely different. Number one, we understand what kind of a virus this is and how deadly it can be, and which populations are the most vulnerable populations. Number two, we have a huge advantage with a vaccine in our arsenal, and multiple vaccines and multiple candidates being developed all around the world by very smart scientists. And we all have drugs now. We have drugs that are already existing, and we have drugs that are being produced by various companies that seem to be quite effective against preventing death and hospitalization for SARS-CoV-2, that are to be rolled out in the coming months. So I think we're hitting we're hitting the curve, and we'll be dealing with a different paradigm next year. I'm optimistic regarding that.
Okay. So what have you seen? I know we had the first surge, or that I experienced with you in the hospital, and then we just had this other surge. What was the difference between the patient populations that we saw from the first surge versus the second surge?
Yeah, so I think we've had about four surges now,
Oh, okay.
and some of them not as clinically relevant as others. But I think I know what you're talking about. I think you're talking about the one we had in Jan, Feb of this year versus the one we had a month and a half ago where we peaked. And that's speaking locally because different parts of the U.S. peaked at slightly different periods of time. And we're in North Carolina right now in Burke County. But I think the big difference was we were dealing with a different variant earlier this year, and we're dealing with a different variant now. And the variant we're dealing with now is the Delta variant, that's significantly more efficient in transferring from one person to another, or is more contagious. And it's estimated that one infected person can infect up to five other people, as opposed to the Alpha variants or the variants we were dealing with before, that were less robust in that respect, and that one infected person would only infect two other people. I think the that's the key factor. Despite the fact that we knew about masks, we had a vaccine, we had good medications, we had a good outpatient infrastructure to help patients who were sick in the community. The virus just got really smart this time on us.
What do you think could have contributed to this mutation? Do viruses just mutate all the time on their own, or what was different this time?
And that's a very good question. And viruses do mutate all the time. That is a true statement. And this was not unexpected. As we speak, the WHO is observing the US, the WHO, and other national and international organizations are monitoring for vaccine for variants, in particular variants that are more lethal, B, variants that are more transmissible, and C, variants that affect natural immunity and vaccine induced immunity. In other words, a variant that makes our vaccines less effective, or variants that makes you more likely to get reinfected if you've already had COVID-19. And the reason why these viruses are good at mutating are that they're simple. They have a very simple genetic code, and when they multiply, when they're given the opportunity to multiply and transfer from one host to another, under the slightly different microenvironment of the host, when they multiply, they make mistakes and they adapt to that particular host, generating mutants. And we have one big weapon against generation of mutations, and that's vaccination. If we can get the numbers down, we diminish the probability of a clinically relevant variant being generated through the pandemic. And vaccines are our number one thing that can actually stop the variants in their track.
Now, if we have people that get vaccinated, people that don't get vaccinated, does the vaccine effectiveness change if we don't have enough of the population not getting vaccinated?
So for those people who get vaccinated, no. And in so much as the vaccinate as a highly vaccinated population decreases the probability of a vaccine escape mutant, I would say the answer is yes. But if a person chooses not to get vaccinated, if you have a high degree of unvaccinated people in your population, then there's a high likelihood that a variant will eventually develop that escapes vaccine-induced immunity.
Okay. Now, there's been a lot of debate over the vaccines that we currently have. Can you just briefly cover the types of vaccines that are available?
Yeah, right now we have three main kinds of vaccines. Well, actually, two main kinds of vaccines with three vaccine products out there. We have the Pfizer BioNTech vaccine. We have the Moderna mRNA vaccines. So both these are using mRNA technology, and this technology is very old technology. We've had this for a while. We've just never used the technology to create vaccines and to mass produce vaccines the way we are for SARS-CoV-2. And these viruses just allow you to directly introduce the genetic code of the virus, the part of the genetic code that codes for the spike protein into the muscle. It's taken up by the muscles. It doesn't enter the nucleus. It just stays in the cytoplasm of the cells that take it up, and then it produces the spike protein that is expressed on the cells. And then your immune system sees those spike proteins on the surface of the cell, and that's how your body generates an immunity to the spike protein, and thereby gives you protection against SARS-CoV-2 infection. So that's the mRNA technology, and the other one is the Johnson and Johnson product, which is an adenovirus vector vaccine, which allows for you, which essentially gives a little bit of the virus genome carried by another virus into your body, allowing that virus to get the genome into your cells. All these three vaccines that are approved are very effective, but as we expect, natural tendency of our own immunity is to over time sort of switch off the antibody production. So after you get the vaccine, you have a good protective antibody level, but over time that antibody level tends to wane away. And at some point, it is hypothesized that the waning antibody levels may predispose people to getting reinfections, and hence the suggestion by the regulatory authorities, the CDC and the FDA, to authorize booster vaccination doses for all those three approved vaccines.
Now, I received my booster, and my question is, do you think this will be something that we may need to get more boosters in the future, like every 6 months, every year? Will this be sort of like the flu vaccine? Is that how you predict this to be?
You know, I I certainly hope not. Even if there are a few more boosters in my future, I hope it's not indefinite. Um, but it does seem likely, given how over time we may need to find ourselves in a spot where we have to generate a booster with a slightly different code of spike protein that it expresses. And that also depends on what variant is prevalent and whether or not the existing vaccination allows us to generate neutralizing antibodies for the variant that's predominantly in circulation. The answer to that, I guess, only time will tell. But I think some more boosters are in all of our futures, as far as at least for healthcare professionals.
Okay. No, when you said it doesn't enter the nucleus, I've had patients who will tell me, "Oh, well, this is like a genetic like vaccine. It's going to change my DNA." Can you explain that a little bit better for individuals who are listening who may be concerned about that? Because again, this comes up and I have to try to explain it to my patients.
Yeah. So for the mRNA vaccines, it's basically a code. It's basically a bit of messenger RNA. And what is messenger RNA? Messenger RNA is a partially processed code that codes for proteins that doesn't need to get into the nucleus at all, because it's already a finished product. The moment it gets into the cytoplasm, the ribosomes inside the cytoplasm jump onto that mRNA and start producing the proteins. So there's no processing that requires to happen inside the nucleus, and the mRNA is not physically capable of integrating into DNA because they're very different. So the short version of it is none of these viruses change your DNA.
So my other question is, if we get vaccinated, should we still continue to wear our masks?
Yeah, good question. So I think the CDC is fairly good about updating its guidance as far as two factors. One is community transmission, and one is your own personal risk, right? Those are the two big things that you as an individual need to think about when you are, you're deciding whether or not to wear a mask, even if you're vaccinated. And I think for most people, if you're in a place where the community transmission is high, and the definitions may vary from country to country, but in the US, it is more than 100 new cases per 100,000 people, or more than a 10% positivity rate. So if there are 100 100 tests, PCR tests done in your community, and more than 10% of them are turning out to be positive every day, that's a high transmission community. And so that's one thing you should take into consideration. And the second thing is your own risk. So if you fall under a group that is considered to be high risk for severe COVID 19, in other words, if you feel like if you get COVID, you're going to land up in the hospital, or you're going to be sick with a need for oxygen or other kinds of medications, uh, then I think it would be better for you to wear a mask despite the fact that you're vaccinated. And of course, anybody who works with other people who are also at risk for a high risk or risk for severe COVID-19 should probably err on the side of wearing a mask, especially indoors. Now, if you have a low community transmission and you're not a person who is at high risk, or you're not dealing with other people who are at high risk in close quarters, and you've been vaccinated and you're outdoors, then there's really no reason for you to be wearing a mask.
Okay. So pretty much we're safe when we're outdoors.
Correct.
And then I have another question about like who should and who should not get vaccinated. Are there a group of people who just should not get the vaccine?
So each vaccine has come out with a few sheets about exactly what the vaccine contains. So if you know that you're allergic to any of those products that are in the vaccine, like polysorbate, then make sure that you don't get those vaccines, because you're likely to react to the vaccine, especially if your reaction was an anaphylactic reaction or a severe drug reaction. So that really is the only absolute contraindication to getting these vaccines. There are some other caveats. For the obvious caveat is your vaccine licensed for your age group? And now we've seen that some vaccines now are licensed all the way from 5 years and above. The other thing you want to think about is, have you received monoclonal antibodies within the past 90 days? And if you've received monoclonal antibodies as part of treatment for COVID 19, then you want to wait for at least 90 days before you go ahead and get your vaccine. And of course, if you've had a bad reaction to the first dose of the vaccine, or an anaphylactic, life threatening reaction to the first dose of the vaccine, you don't want to get the second dose of the vaccine. But besides that, there's really no reason for somebody not to strongly consider getting a vaccine. And if you're in a gray zone where you feel like you have reacted to other vaccines in the past, or you've had anaphylaxis to other vaccines that don't contain the same things as the COVID-19 vaccine, but you're concerned, then you can talk to an allergist or an immunologist, or your PCP to get reassured. Make sure that you're monitored very closely for an extended period of time after you get the vaccine, so that you can protect yourself and do so safely.
Okay. And I'm also getting some individuals telling me, well, the vaccine doesn't seem to work anyways. So and so got the vaccine and they still ended up getting COVID, or someone ended up in the hospital who had the COVID vaccine. Can you talk about the effectiveness of these vaccines, please?
Oh, absolutely. So these vaccines are extremely effective. And when I say extremely, I mean extremely effective. It's hard for us to determine efficacy of a vaccine now that most of the population who's at high risk, in some places in the US, you have up to 95% of people above the age of 65 who have already got one dose of the vaccine. But when you look at admissions data and you look at mortality data, and even in our own hospital experience, over 80% of all the hospitalizations that we are seeing, and in some studies, over 90% of all the hospitalizations we're seeing related to COVID 19, are all in the group of patients who have not got the vaccine. So the vaccine is extremely effective. You're protected up to 25 times less likely to be hospitalizations, and up to 25 times less likely to die of COVID-19 if you've been vaccinated. So definitely, I'd like to debunk that myth very, very strongly.
Yeah, I keep talking to people and trying to debunk some of these myths, but no other person to hear it from, I think, than an infectious disease physician. And I basically follow what you say. I've done it, and so far it's been great advice. I've stayed safe. My family has stayed safe. So definitely appreciate you. Is there anything else that I didn't ask you that you think I need my listeners to know or we need to?
Absolutely. Dr. G, I appreciate you following my advice, but truly, none of this is really my advice. It's the advice that I've heard from experts of the field, the CDC, the FDA, and I look into the data that they have looked at to make their own decisions. And I think if people knew where to look for good information, I think we'd all be really on the same page. I think places that you should avoid going to for information would be social media platforms. Places you should avoid going to for information related to COVID 19 is news networks. I think the places you should go for COVID 19 related information is the FDA and the CDC. Every single medical management decision that doctors make is rooted in these organizations' decisions. And that's the foundation of medicine that's practiced in the West. So I strongly urge your listeners to look for information in the right place because there's a lot of misinformation out there.
Okay. I guess I had two more questions. So right now is the season, for the flu vaccine. Can people get it at the same time?
Yes, people can get the flu shot and COVID 19 shot at the same time.
And then I guess I had one more question. If you have had COVID, should you still get the vaccine?
So the CDC does recommend people who have had COVID 19 to go ahead and get the vaccine. And there's evidence to say that natural immunity is quite good. And there's some evidence that says that if you have had COVID 19, your natural antibodies against COVID 19 would keep you protected for up to 8 months out. But there's also evidence that says that if you're relying purely on your natural infection for immunity, you're going to be 2 times more likely to get reinfected than somebody who's got the vaccine. And arguably, the best protection you can get is if you've had a natural infection and you can get the COVID vaccine after that, your body's immunity would be very robust. Of course, I'm not in any way recommending that you go out and get infected because this is a fatal disease. We are seeing even young, relatively healthy individuals fighting for their lives in the hospital.
Yeah. I mean, I think that from my standpoint, the palliative care service line definitely got busier, unfortunately, because of the COVID 19 patients that we had. And we were seeing younger patients, which was very disturbing to me because as a geriatrician, I'm just used to seeing older patients. It's actually hard for me to treat young patients. And so I wanted to make sure that we covered this. So boosting, yes, yes, because this episode is called Boost, not Boost. So we're going to boost, right?
Absolutely, yeah. I think the FDA has come out with very clear, good guidelines. CDC has adopted those guidelines. If you're in that age group above 65, or between 50 to 64 with some high risk conditions, or if you're in an occupation that puts you in close contact with other people who have COVID 19 and put you at risk for acquiring the virus, then and of course, that's not an exclusive list, then you're eligible for a booster shot. For the mRNA vaccines, for the Pfizer BioNTech and the Moderna vaccine, you can get your booster shot after 6 months. For the Johnson and Johnson vaccine, you can get your booster after 2 months, and you don't even need to be in a risk category for the J&J booster. You can get it even without being in a risk category if you're 18 and above after 2 months of the first shot.
Okay. And then how long after you've had a COVID infection should you get vaccinated?
So the CDC doesn't really recommend that you wait any particular period of time. Once you get over your COVID-19 and you're out of your quarantine period, if you're out of your isolation period, then you can go ahead and get your COVID shot. Now, there's a caveat. If you've suffered from multi-system inflammatory disease with your COVID-19, wait 90 days before you get your vaccine.
And what does that mean?
So there's a rare multi-system inflammatory syndrome that's been described with COVID-19. It usually affects children They come in with very high inflammatory markers. They usually require a lot of immunosuppression. It's related to dysregulation of the immune system, not so much of the actual virus infecting the body. So in those situations, the CDC has recommended to wait for 90 days.
Okay. And another thing I wanted to just briefly touch on, sorry, I'm keeping you on here for a while, but I really appreciate these answers. So for patients who end up with these long haulers, right? They have COVID symptoms after they've had the infection. And so, you know, I guess I talk to patients about that too. Like, hey, if we get the vaccine, then you're not going to have these symptoms, right? Is there evidence at all for patients who actually get the vaccine who may get COVID that they recover better and don't have these symptoms? Do we have that data yet?
I have seen some of that data. Unfortunately, I haven't gone through that data in too much detail to be able to discuss it. But there is a decrease in long haul COVID, which is a diagnosis that's evolving. We already have long haul COVID clinics. You can have a post COVID syndrome, and you can have long haul COVID. Different groups have come out with different time frames and definitions. So it's a moving target. But there is some data that says that being vaccinated decreases the likelihood of you getting post COVID syndrome, even if you get COVID 19.
But thank you so much. I have no other questions. I think you've answered so many of our questions. And again, I appreciate you and the work that you're doing. And I'll see you around at work in the hospital.
Likewise, Dr. G, we all appreciate what you do in the hospital too. I don't know how our hospital can run without you around, your team, your geriatric team, your fellows. You're just a bundle of energy, and your dynamism is contagious, and we enjoy it. We truly enjoy working with you. So look forward to seeing you around the hospital.
Thank you so much. Have a great day. Thank you for listening to this episode of the Jerry Academy podcast. Learn more at jerryacademy.com or follow me on social media for information on future episodes.